Well, hello everybody, and thank you for tuning into this presentation. This is an important presentation for two reasons. First is I wanted to review generally what ECT is and how we use it and what the risks and benefits are. But also for anyone who's starting a medical treatment, I wanted to quickly review the importance of informed consent and when families and patients are making the decision to take a treatment, how important it is that they fully understand what informed consent is and how it can make that decision happen. We definitely at BC Children's Hospital, we rely on the knowledge that families and patients have given informed consent for treatment. And that means being able to ask questions, to understand the nature, etc. So informed consent in general is deciding on a treatment and knowing the following information. You understand the diagnosis in which the treatment is being offered. You understand what the recommended treatments are for that diagnosis. You should know what the effects of treatment are, both the positive effects or the negative effects, or what some people call side effects. And you also need to know what the effects of non-treatment are. So if you decide not to treat, could there be any benefits or negative effects to that? You should have an opportunity to ask questions to your satisfaction in making the decision. You should understand all alternative treatments that are available for dealing with that issue. And you should also be able to understand your right to refuse the treatment, or what we call informed dissent, the ability to say no to a treatment and know that it won't negatively impact you. So ECT in general is electroconvulsive therapy. It's been around for a very long time, and generally what it does is it introduces electricity into the brain to induce a seizure. It's a medical procedure. It's performed under anesthesia, and when ECT is given, because of the anesthesia, the patient is both asleep as well as being given a muscle relaxant so that they're effectively paralyzed and their muscles won't work. This is very important because before we used anesthesia and before we used muscle relaxants, ECT was associated with pain, and ECT was associated with arm and leg and back injuries because of the movements involved. So even though the seizure itself is short and the whole procedure is short, by using anesthesia and muscle relaxants now, we've actually significantly improved the experience for the patient such that they don't feel any pain and we barely get any movement during the seizure. But of course, ECT was made very famous by the movies. ECT is famously portrayed in an older movie now called One Flew Over the Cuckoo's Nest, but you don't have to go that far back. Many times ECT is portrayed in the movies. It's portrayed in a way that we don't perform it. So it's really important to know that if you've seen ECT on TV or movies, it probably is very different than how ECT is done clinically. So when we do ECT with patients and we ask them about the experience, they generally have a hard time remembering the experience in general. They don't report pain during the procedure, and they're asleep for the procedure, so they shouldn't feel pain. There's no violent convulsions when someone is doing ECT, and typically the motor seizure is very small. So when I describe it to medical students, I'll describe it as the beat of a toe moving for about 30 seconds. Patients don't experience burn injuries, and the electricity doesn't zap through the air. There isn't a loud electrical noise. And because of the use of anesthetic and muscle relaxers, it's a very humane and does not cause pain in terms of its experience. We never use ECT as a punishment, which is one of the ways it was used famously in the movies. Whenever a patient got out of line or did something that the staff didn't want, ECT would apply. That's an unethical use of ECT today, and we would never use it in that way. So it's not used to control behaviors or as a punishment. It's really important to address this stigma of ECT, because whether it's describing getting ECT to other people, or whether or not when a doctor first introduces the idea of ECT, the images of media and movies in our brain can really predominate, and we call that stigma. And the realities of mental health treatments are often very different than the way that the media or the general public perceives them. So how does ECT work? The simplest answer is we actually don't know how ECT works. The brain is very complex. We have a long way in going in understanding how ECT works. We know for sure that it can improve the treatments, that the diagnoses and the outcomes that we're looking to improve. And we know that it changes both the physical nature of the brain, the way seizures are experienced in the brain and can actually increase the brain's resistance to seizures. It can change the way that nerve cells communicate with each other, both through blood flow, the actual attachments of the nerve cells to each other, and the way that chemicals and neurotransmitters work. But it should never be assumed that, oh, ECT causes changes by adjusting neurotransmitters, or we want to increase the serotonin of the brain, or we want to cause a certain area to grow or a certain area to shrink, because we don't have that knowledge of how ECT makes its changes. We know that it works, and we know some changes that are made, but we still have a long way to go to figure out how to relate those changes to the improvements that we see. So if you ever need a simple explanation of ECT's effect, we can say that we know that it works, but we're not sure why. When do we use ECT? Well, I've created this graph to kind of show that there are some situations in which ECT should be almost always considered. So catatonia, which is a very severe rigidity, change in behavior, stuck pattern of automatic behavior due to a severe mental illness, ECT is curative and has extremely robust evidence. In bipolar disorder, it has great evidence. In depression, it has great evidence. In schizophrenia, it does have good evidence, especially when used with other medications or in treatments where medications aren't working, but the evidence isn't as strong. And then for suicidality, we still have a long way to go to understand whether or not ECT has a major role in preventing suicides with people with mental illness, or if it doesn't. Depending on the indication that's being proposed, the diagnosis that's being given to you as a family member, the evidence for ECT can change. ECT is not used in some situations like anxiety disorders and personality disorders and other things like that. It may not be helpful at all, but there's no absolute reason not to use ECT. So typically people will say, oh, this person already has a seizure disorder, maybe they can't have ECT, and that's actually not true. Patients with ECT, with seizure disorders who've received ECT have experienced benefit, but we do have some special concerns when patients have brain disorders such as strokes, brain bleeds, or aneurysms. We would be a little bit more cautious. If there's increased intracranial pressure due to a tumor in the brain or something like that, we'd be more cautious. And because anesthetic is required, any problems with the lungs, sometimes the heart, might be a reason to say no to ECT. But these aren't absolute indications. They don't guarantee that ECT can't be delivered. And in all cases, because of the severity of the issue that's being dealt with, it could be that the risk of ECT is worth it, depending on how severe the underlying condition is. So when we are talking about ECT and you're thinking about it for your family member, you want to consider which indication is it being used for. And so when your doctor is explaining the treatment to you, there should be an explanation of what the diagnosis is that the ECT is designed to address. There are all alternatives to ECT. You can choose not to do ECT and just not treat the underlying problem. Of course, that has the least chance of inducing a change, but the greatest chance of not causing a side effect. What I mean by that, and in this slide, I've kind of shown that if you think about treatment and non-treatment as having side effects, if we choose not to treat, typically we're guaranteeing the least amount of treatment side effects, but we're also opening up the door for non-treatment side effects in the greatest degree. Sometimes environmental, comfort, social changes can be made to address an issue, and that can have good effects and generally has low side effects. But typically doesn't resolve major issues like schizophrenia, catatonia, bipolar disorder. There's obviously psychotherapies, which are much more helpful in disorders like depression and suicidal thinking, a little bit less so in schizophrenia, though there's some minor benefits experienced, and almost no benefit to psychotherapy in catatonia. And then in medications, we do try medications usually first before ECT, and medications have a large list of side effects as well that need to be considered, but are major mainstay treatments of most psychiatric disorders. Frequently, the first thing we think about is, does ECT work? And we can say pretty definitively that ECT does work. The most amount of evidence, as I said before, was in catatonia, and the rates of recovery in catatonia are huge. 73 to 100% in studies. Obviously, by that nature, it's not 100% because multiple studies add up to less than that. But it's really important to think of catatonia and ECT as related, especially if catatonia is causing severe symptoms like an inability to eat, changes in the way our heart or our temperature is working, what we call malignant catatonia, or catatonia that does not resolve with medications. ECT is the treatment of recommendation and is generally curative. In depression, it's probably underused. It has one of the strongest effects out of all of the antidepressant treatments we have. It compares very favorably and in fact outperforms psychological and medication treatments for depression. However, because of the nature of the stigma around it, the difficulties in accessing it, and the coordination required to deliver it, I think it's probably chosen for depression. But it has a very strong effect in depression, and particularly if there's a depression that also has psychotic features like hallucinations or delusions, or a severe amount of withdrawal. In schizophrenia, typically we use ECT along with a medication, or what we call adjunct treatment or combined treatment. And in those situations, response to ECT is very strong, about twice as likely as not using ECT. Schizophrenia is a very disabling condition, and true remission when you're at the state of trying medications that aren't working is rare, but it's still 3 times more likely with ECT than not, although overall full remission is unlikely in refractory schizophrenia. In suicidality, we know that there's a 20% reduction of suicide for people who've received ECT versus those who haven't. But it's very difficult to design those studies because of how rare suicide is in general. So this is where the evidence is probably the weakest, but we still may consider ECT as an effective treatment for severe suicidality that isn't responding to medications or psychotherapies. When we ask patients in formal surveys how they feel about it, ECT is rarely delivered, so we don't have gigantic numbers of these surveys. In a Mayo Clinic survey, 91% of patients endorsed being glad that they received ECT. In another survey of 64 patients, more than half would choose it again if given the choice, and certainly much more commonly than saying that they would be unlikely to choose it again. There was a group of people in the middle that weren't sure. There was a survey done in 2018 of the United Kingdom in which they got 55 patients, all patients who got ECT during that survey, to provide feedback, and they just left an open text box and said, write your feedback about ECT. And it's important to know that when patients weren't constrained to survey questions and just given the open chance to share their experience, 116 of the 116 comments were positive. There were no negative comments given about the ECT. And the NHS has guidelines for how to deliver ECT. So patients out of 5 highly scored whether or not they'd recommend ECT to others, whether or not they were treated with dignity, if they were involved in the decision-making, if they were given enough information, if the staff were respectful. And so the NHS survey really showed that when ECT is delivered in a way that's respectful and with informed consent, most patients actually rate ECT very positively. But it's important to know that many patients, especially online, if you do any Googling about this or hit Twitter about it, or hear some YouTube stories, you might hear some stories that are shared that are scary. Many patients have reported feeling coerced or forced into having ECT, which obviously should never happen. They felt not heard when they were reporting a side effect. They felt that they weren't receiving a fulsome discussion like the one that I'm having right now in this presentation. And they report that they didn't hear anything about side effects. In fact, some people who received ECT were told that it was perfectly safe and that there were no side effects to ECT, which of course is not true. So this presentation and the discussion that you should have with your doctor when receiving ECT is intended to counter that idea. We never want to minimize the experience of patients who've had a negative mental health outcome. And so by listening to those stories, what we've tried to do is create presentations like this and documents such that patients feel engaged and listened to, and that they know the benefits and risks of the medication, of the ECT treatment. Now, I work for Children's Hospital, and so whenever I mention ECT, people say, can you do ECT in children? It's much rarer in children. It does not seem to have increased risks in children. The evidence for ECT is mostly based off of individual case reports. And myself personally, I've only been involved in a handful of ECT cases. And it's in kids, because of the nature of our unclarity, our lack of clarity on ECT in children, we would typically only reserve it for the most emergency of situations. So a very severe illness that isn't responding to treatment, catatonia that is turning quite dangerous, with a child being stuck or unable to eat or something like that. And then recently there's been increasing evidence that in severe autism, where a patient is experiencing significant and life-threatening self-injury, this could be due to what we call excitatory catatonia. And we treat this with medications first, and if that doesn't work, we might try ECT. And we've had some excellent results with that. This is being reported more and more across the world. But it's important to remember that all of those emergency situations are dangerous and harmful in themselves. And so the risk of non-treatment is very high, and the risk of treatment, especially for ECT, as we'll discuss, the risk of treatment in ECT is actually relatively low. There are some things that can happen, but the risk of non-treatment is very high because these conditions are so dangerous. And so when balancing the decision as a caregiver or as a patient whether or not to receive ECT, you always have to keep in mind that not treating could be very dangerous itself. And so sometimes people feel the weight of just determining the dangerousness of a treatment, and it's relatively easy to forget what might happen if there is no treatment given. Most patients, adolescent patients who receive ECT, similarly report it well. So we've had a handful here at BC Children's Hospital. Many sites throughout North America and in the UK have reported adolescent outcomes, and generally adolescents report ECT as favorably as adults do. What's the structure of ECT? Typically, when ECT is offered, you will get some sort of ECT clearance where a preoperative clinic will assess your lungs and your heart and your ability to receive anesthesia. And usually for kids and for many patients, a second opinion for ECT is sought, in which an independent clinician is brought in to assess whether or not the agreement that ECT is the right procedure to be given. This clearance procedure for non-emergency conditions can take up to a month. This clearance procedure for emergency situations can take just a few days. Usually, to get a treatment started, you're looking at 10 to 4 applications of ECT. ECT itself is a very medicalized procedure. So you go in, you check in, lie down on the bed, the electrodes are placed on, you're given an anesthetic and a muscle relaxant to go to sleep. The anesthesiologist team will support your breathing while you're asleep. The ECT is delivered through a stimulus that takes about 3 to 5 seconds. The seizure itself lasts about a minute, and then the recovery process begins, where the anesthetic is removed, the breathing becomes your own again, and you don't need the anesthesia team to help support that, and then typically the person will wake up. And so the whole thing from start to finish takes a very short amount of time, and you can expect to be in the hospital for anywhere between 30 and 45 minutes in a typical ECT session. After the 10 to 14 treatments, it could be that the determination is, all right, things are better, we don't need to do ECT anymore, or sometimes you need to do what's called maintenance ECT, where weekly treatments or every 2 weeks, every 3 weeks, ECT is given. Some patients need rescue ECT when symptoms come back very quickly, and so it is really important to be checking in and making sure that you understand the course of the ECT with your doctor and what's being recommended. The anesthetic is given by IV, so there is an IV that's given for patients with neurodiversity. This can be challenging, so we try and minimize the amount of time that patients are meant to wait, and when it is time to give the ECT, the anesthetic through the IV, it's important for it just to happen quickly so that the patient be put to sleep, because patients with neurodiversity can really struggle with blood work procedures generally and all needles. So it's important to know that the patient is asleep for the whole duration of the ECT, and they don't remember it, both because of the nature of the seizure as well as the fact that they're asleep for it. And patients recover very quickly, usually out of the hospital in about half an hour. There are risks to ECT. The first risk that we think about is the risk of anesthesia itself. So all patients for all procedures, all surgeries, whether it's a minor tooth procedure or a major heart surgery, there is a risk to the anesthetic itself. We know that for generally healthy people, the risk of anesthesia resulting in any major outcome is very low. The chance of death due to anesthesia is 1 in 80,000, which is quite low. But it is something that's possible. There is no special risk to death with ECT compared to other forms of anesthesia. Because we're inducing a seizure, when someone has a seizure, we try to relax the muscles so that there's no movement. But if there is any movement, say there's an error in giving something, it could be that there is movement, and that movement could cause injury. So if the muscles aren't sufficiently relaxed, someone can bite down very hard, and that can cause tooth problems. There's usually a bite blocker in so that there's no tongue or tooth injury. There can be limb problems if the limb is moving, so an injury to the limbs like a bruise or a broken arm. This again would only happen if the muscle relaxer wasn't properly given or there was a strange reaction to it, which is very rare. Because we're inducing a seizure, it can be that we start a seizure that doesn't stop. Fortunately, the safest place to have a seizure is in front of an anesthesiologist and a doctor with medication who can stop a seizure. So if a seizure goes on for longer than 2 minutes, we prepare to stop it. And if it goes on for longer than 3 minutes, we would give medication to stop the seizure. But of course, breath is supported the whole time by the anesthesiologist. So there isn't as much of a danger of choking or major outcomes of a longer seizure like there would be if one were to have a 3-minute seizure with nobody watching. ECT specifically can have side effects not just because of the anesthesia or the procedure. Many patients report having a hard time forming new memories when they're giving treatments. And so this typically is like, I don't remember the day of my treatment, or I don't remember what I had for lunch that day. It's usually autobiographical in nature, the things I did. It's not forgetting how to eat or forgetting how to do things. It'll just be the memories formed of those times. Usually when ECT stops, those memory problems are not permanent, but you'll still not remember the time of the ECT very well. That's a commonly reported thing. So those memory problems are expected. It's not common to remember a lot about your ECT treatment. Almost all patients will develop some form of permanent memory loss of the treatments themselves. So that's expected, common, and will happen. And we expect people to know that that's going to be a side effect of the ECT. There's a smaller percentage that report more severe memory problems that continue after treatment. We don't know as much about this. There's many patients who report it. When we systematically look at it, it looks to be about 1 to 2% of patients, but we don't know what the final number is going to be. So it is important to know that one of the outcomes of ECT can be a more permanent memory problem in which there's a harder time to remember things, usually autobiographical, things in my history. Oh, I don't remember my teacher's name, or I don't remember what I did in school that year. So autobiographical things, but some patients have reported difficulties in remembering how to do things as well. So if that were to be a side effect, that would obviously be a major side effect. There are other patient reports of severe nervous injuries, like difficulties with moving or problems with swallowing. But when we've systematically looked at ECT outcomes, we haven't seen those very frequently at all. So there's a pile of unknown neurological side effects that we can't account for yet. So if we see side effects for headaches, for example, which is commonly on the day of ECT, one can get a headache. Simple Tylenol or ibuprofen, acetaminophen or ibuprofen can be given on the day of the ECT to minimize that. And most patients report that that works very well. For the memory and thinking side effects, we can change the placement of the electrodes, which can minimize the amount of energy given. It does make it harder to induce a seizure. So there can be some challenges in moving the electrode placement, but if we're trying to avoid memory side effects, sometimes we can modify the way that we deliver ECT. And then we want to be monitoring for cognitive side effects throughout the ECT treatment. So not just a simple how is your memory, but actually, systematically going through memory, cognition, counting, the ability to do math, the things that were there as a baseline, and then complex cognitive testing throughout and then after. If ever side effects became problematic, it might be necessary to stop ECT. So if that were to be the case, then ECT would would be taken off the table, and ECT can be stopped because of side effects. About 20% of patients who start a course of ECT have to stop it for some reason. Either the timing doesn't work for them, the problem gets better, they don't want to take it anymore, or they're having a side effect for it, and they need to stop it. So about 1 in 5 people who start ECT will stop it before the full treatment is done. After ECT, it's important to know not to drive if you're someone who can drive or operate heavy machinery or do anything that requires concentration or attention, especially for the first 3 weeks of treatment and on the days of ECT. It's best to treat those days as rest days. We want to obviously lessen expectations of what you have to do during those times. So it's not the best time to be doing chores or homework or those types of things. And in fact, the whole focus should just be on resting and relaxing. We want to follow up with people how they're doing throughout the course of treatment, but it's really important to tell your doctor if you're experiencing something as well, if things aren't working well, if you have any questions. So you should have many opportunities to provide feedback real time to how things are going, and you should feel listened to. And we're going to talk about this more in the next slide, but you consent for treatments, and then you can remove your consent for treatments. So whoever decides, yes, I agree to this treatment, can also decide, I no longer agree to this treatment. So this isn't like a cell phone contract where you're bound for years, and it's going to happen no matter what you want. Consent for medical procedures can be removed if you no longer agree with that consent. And that gets us into the right to refuse treatment. When saying, yes, I want to give a treatment, that's implied that you're voluntarily able to say that. The corollary to that is if you say that you can do something, you can also voluntarily say, I don't want to do that thing. And so this is called the right to refuse treatment or informed dissent. After hearing everything, you can choose, I don't want to get ECT. It's a reasonable thing to do, and it's your right to do so. We require consent for all of the treatments that we do. So if we don't get your consent, we can't do the treatment. To properly consent, you need to be informed, and after you're informed, you can choose not to consent, which is saying, I do not want this treatment, I refuse it. It's informed dissent, and we respect that just as much. If we're really concerned about someone's welfare, and the person we're asking is giving us an answer, and we think, oh, because of the nature of their brain, they can't make that decision, we are required to go to an independent body, not ourselves. Usually it's a family member in the case that a family member is available. If that's not available, it would be a trustee or a public trustee to make that determination, and it's not the treatment guardians or the treatment providers. So whoever is responsible for giving consent can give dissent. So if you give dissent, it's really important to not feel coerced. You should feel like you will still get the top quality care that you can receive, that your treatment team and your doctor will still treat you with respect, and that you won't be put on some new pile of treatment because you've chosen not to take the treatment. It should be that your decision is respected. And that's a standard that I hold myself to, and that at Children's Hospital we hold ourselves to. So that brings to the last point. Now, obviously, this is a non-interactive video, but after receiving information on ECT, you should be able to feel like you can ask questions. And your questions should be thoughtfully considered and responded to. If the answer isn't immediately available, it should be sought out. And if you have more questions, you should be able to delay making a decision in order to get those questions answered. A program like the Kelty Mental Health is there specifically to help with questions and answer finding, and also in parent and child support for making decisions. So never forget that asking questions is a vital part of informed consent. So when considering ECT, asking questions is a must. So that's my presentation. There's a lot more to know about ECT, and that's why the questions are so important. I hope that overall, after seeing this, whoever's watching it understands how important it is to understand what informed consent is, all of the risks and benefits that we know about ECT, and then making the decision with the best of your abilities. If you're someone who's currently considering ECT, it's probably a situation in which you didn't anticipate being in, and having lots of questions and needing things repeated is understandable. So if this is your situation and you need more time, reach out to the Kelty Mental Health team, reach out to your treatment provider, take the time that you need to make the best decision you can. So I'm Tyler Black for BC Children's Hospital. It's a pleasure giving you this presentation.